Welcome to the Dr. Journal Club podcast, the show that goes under the hood of evidence-based integrative medicine. We review recent research articles, interview evidence-based medicine thought leaders, and discuss the challenges and opportunities of integrating evidence-based and integrative medicine. Continue your learning after the show at www.drjournalclub.com.
Please bear in mind that this is for educational and entertainment purposes only. Talk to your doctor before making any medical decisions, changes, etc. Everything we're talking about, that's to teach you guys stuff and have fun. We are not your doctors. Also, we would love to answer your specific questions. On drjournalclub.com, you can post questions and comments for specific videos, but go ahead and email us directly at josh@drjournalclub.com. That's josh@drjournalclub.com. Send us your listener questions, and we will discuss it on our pod. Okay. Hello. Welcome to another Dr. Journal Club podcast. This is your host, Dr. Goldberg and Dr. Sadowski. Adam has an interesting handle on his screen right now, which I'm not going to read out loud. Anyway, so Dr. Sadowski, how are things? How are you doing, sir?
I'm doing great. How are you?
I'm doing good. I was just thinking, I just love coffee so much. So much.
It's my drug of choice.
Oh, absolutely. It gets you going, but also just the culture of it, and so.
Anyway, are you a snob?
I don't think I'm a snob. I'm just a nerd. I really love coffee. I like to roast my own coffee. I mean, not continuously, just to experience it. I read books on coffee making, and then it's on my mind because our neighbors invited us over the other day, and they're from Jordan, and they treated us to Turkish coffee.
Oh,
have you ever had Turkish coffee before?
I have. There's actually a really cool, I guess technically it's not even a cafe, but there's a really cool spot in Portland where it's an old, English two-top bus.
Uh-huh.
So it's
like
a red bus with two layers.
Yeah.
And it's actually an Egyptian cafe, and they do Turkish coffee.
Oh, neat.
And it's really
Portland's
cool.
Cool. Portland's so cool. We got to talk about your move soon. I feel like you're going to miss Portland. But anyway, so I'm hooked now. I went and bought the special Turkish coffee, boiling.
The sand oven things.
Well, it's I don't know what you call it. It's sort of it almost looks like a ladle with a bowl on the bottom. Mm-hmm. So you do multiple rounds of boiling. It's neat. There's a whole different way to prep it, and it's got cardamom in it. It's just really different, and I don't know. I just love it. I love coffee culture, and I think I would be open to trying all forms of coffee, with the exception. I think now this might just be a myth, but I feel like aren't there type of Ethiopian beans that have been fermented in the GI tract of a puma or something like that? Have you heard of that?
I have no idea.
It's a thing. I'd say Google it, but I'm worried about what you find. Maybe ask ChatGPT without images. I feel like it's a real thing, and it's a special type of coffee bean. And someone might have just pulled my leg on this, and it's not actually a thing, and I've been believing it all this time. But anyway, I feel like the only thing I would probably not try. But
I love how you describe that though, of being a coffee nerd. I think that's a good description, because I'm the same way. I'm not a snob about it.
Mm-hmm.
There's definitely coffee snobs out there.
Oh yeah,
and they annoy
Hello,
me.
Seattle.
But yes, I also have a huge obsession with coffee, and I think that if you can find a good cafe and you have good coffee, it's kind of hard to actually go back to just drinking sort of standard type of coffee. But I have no issue going to a Starbucks either, and just
I don't mind Starbucks. I think the Starbucks is great. I mean, they have some of the the Clover machines and the I don't love their espresso drinks, but the Clover machines are incredible. I got into doing nitrous oxide, the nitro, and then I have it at home too. I've started using little cartridges, and again, just to play with it because it's fun. But yeah, no, I totally so I think I got this from my dad, because he's always you need to find a cafe and cafe culture or whatever. So he finally moved out here after years of me trying to get him to move here, and the biggest issue we had was we needed to find him a place that was close to a cool coffee shop. And it's not like Seattle, because like he spends half his day, literally every day, in a coffee shop, like working on research or reading the Talmud or something. But he's there with his in a coffee shop. So it turns out like we finally found an apartment for him, and I was so happy because he was so close. But I was like so heartbroken because I knew between me and a good coffee shop, he'd probably leave me for a good coffee shop in downtown. There were a couple good ones, and I was like, no, gotta stay. Randomly, literally across the street from his apartment complex is I didn't know about it at the time, but the best coffee shop in Colorado Springs, and I would argue probably in Colorado, and like better than or close to all the fancy coffee shops that I've been at in Seattle, Portland, etc. And it's just kind of like worked out great. Anyway, I'm on a major coffee tangent, which probably tells you that I'm over caffeinated. So let's jump into the study today. What are we talking about today, Dr. Sadowski?
So it looks like today we're talking about curcumin, which is the active ingredient, if you will, in turmeric. And turmeric is that orange-looking root, or that herb or spice, if you will. That's often used in curries, and it gives it that orange color, that orangey yellow color that stains everything that you touch.
Right.
And from a traditional standpoint, it is viewed as very sort of anti-inflammatory, if you will. And there's a ton of research looking at the anti-inflammatory effects of curcumin for a variety of conditions. And in this particular study, they were actually comparing curcumin to omeprazole, which is one of the more common proton pump inhibitors. Brand name is Nexium. We don't have any sort of financial disclosure there, but just for those who are not
Wouldn't it be
familiar
hilarious if we were sponsored by Nexium as a naturopathic integrative evidence-based medicine? I mean, for all those reasons, including the evidence-based medicine rationale. If we were sponsored by Nexium, but no, we are not sponsored by Nexium.
That's also like the purple pill. For those of you who remember it from the commercials. But yes, they basically looked at, or they compared curcumin to omeprazole for a condition called functional dyspepsia, which is basically just indigestion that doesn't have any sort of other explanation as to why it's occurring. So it's not, indigestion due to an H. pylori infection or gastroesophageal reflux disease or any sort of ulcers or something like that. It's basically, hey, you've got this indigestion. We don't know what's causing it, but there's nothing that we can find that's causing it. You're probably healthy.
Well, we'll give you a diagnosis.
We'll give you a label, but
you don't have
there's
like
nothing to worry about.
Cancer or IBS, so we've categorized it as something else. But yeah, it's a frustrating diagnosis to be sure, and like horribly underdiagnosed.
Well, I'm sure.
Yeah, there's and actually at NUNM, where we both are at HealthGot, where we're affiliated, there is a research trial underway now, and I think they're having a hard time recruiting for functional dyspepsia because like they were shocked. They're like, well, it's so prevalent, and I'm like, it's not so surprising if you would have asked a GI doc, because nobody diagnoses it, even GI docs, when they meet criteria. So yeah, it's prevalent, but if it's not on their records, they're not going to be able to come in and get recruited. Anyway,
and I'm sure a lot of people just kind of get the label of GERD because they're saying that they have some sort of a reflux, even though
IBS. GERD or IBS.
Yeah, even though there is a distinction between it if you actually look at the definition. According to the Rome 4 criteria, which is the most updated version of sort of how we diagnose it. It's basically fullness after meals, early satiety, epigastric pain, so kind of pain kind of in that upper middle area of your stomach above your belly button. And there's no sort of structural disease. So if they were to do an endoscopy, they wouldn't find anything. You wouldn't have H. pylori on some sort of a breath test. You're not having any sort of ulcers. You're basically kind of having these like IBS, like abdominal pain symptoms with symptoms of indigestion.
Right. Well, and you don't need pain for the diagnosis, which is interesting. Which is why it sort of gets separated out from IBS, because with Rome 4, you need pain for an IBS diagnosis. So, I mean, and also it's a weird diagnosis because by definition, at least according to Rome 4, and I've got my issues with Rome, you need imaging or workup. Like it has to be that it's not, that you've had proper like an EGD or something, and it's not something else, like you said. So that's also kind of hard for the diagnosis. Is if someone comes in with a little bit of indigestion or fullness after eating, right, or discomfort, are you gonna force them to get scoped or imaged? So that's an issue too. But we should also say thanks to friend of the pod, Dr. Tucker Winship, who recommended this paper for us to read today. He actually took over the evidence-based medicine critical eval class that I taught at Bastyr when I moved out here. So awesome to Dr. Winship. Thank you very much. And all you listeners, always feel free to send us out some papers. Okay, so I'm just going to read the title before we jump in further, and we'll have a link, but it's Curcumin and Proton Pump Inhibitors for Functional Dyspepsia, a randomized double-blind controlled trial by, and I'm going to butcher the name, it's Thai, Kongkam, Kongkam, 2023 in BMJ Evidence Based Medicine Journal. All right, so I think that was a good initial insight. Any first thoughts on reading it? We both kind of did a glance over this morning in preparation, and we kind of like to not over prepare for these so that we can explore it and discover it with you, dear listener, and see what we look for. So what were kind of like the first things that you circled or highlighted when you were first looking at the first couple pages or so? Anything pop up right away?
Well, I mean, just in general, this was a really well reported paper, meaning that it was very clear to follow. There wasn't confusion. I wasn't kind of jockeying between this manuscript, the supplement material, looking at tables, and kind of like, having tons of papers on my desk trying to figure out, where they found things. They were very, very clear, simple to follow. It was a really, really well organized, written out paper that I think just about like if you're just getting into evidence-based medicine, I think that this would be an excellent sort of first paper to kind of look at and kind of practice the skills. So that was kind of the first thing. But I mean, if we start from the top, things that kind of stood out to me. I did read the introduction because it's not a condition that I'm, overly familiar with. So I was kind of interested in it, and I thought it was interesting to see. And what I did like was they kind of showed what the evidence for the sort of standard of care is as a background. And, they mentioned that proton pump inhibitors are commonly recommended, and based off of a 2017 Cochrane systematic review with meta-analysis showed that the number needed to treat with omeprazole or just proton pump inhibitors in general is 11. So if you treat 11 people with a proton pump inhibitor, at least one will have benefit in their functional dyspepsia symptoms. And then also sort of
more than what would have happened with placebo. So more than 1 in 11 will benefit, but 1 in 11 more over placebo. Yeah.
And then they also just mentioned that proton pump inhibitors can be controversial because
because
of all the things. And I don't know. I don't really know where I stand on that, just because I feel like those concerns can be a bit overblown. Obviously you don't want to be on a medication longer than you need to be. And I think that this is a medication that's oftentimes overly prescribed and overly accessed when perhaps it doesn't need to be. But nonetheless, they kind of, they staged it so this way it was that they're letting us know, okay, hey, here's what the standard of care is. Here's some background data to show why people are using curcumin. And there appears to be some evidence that curcumin does have some promise in functional dyspepsia, but lacks head-to-head data. And they were actually deriving their research from a very recent 2023 Cochrane review, which I thought was cool. But that Cochrane review looked at what they labeled as Chinese herbs, sort of just more generally. But it appeared that turmeric seemed, or at least curcumin derived from turmeric, seemed to have some data, but lack of head-to-head trial, which is why they wanted to do this trial.
Yeah, I thought that was interesting. Yeah, I agree. I thought it was super well reported paper, very clearly written. Yeah, and I also thought it was cool that there was a Cochrane review both on PPIs being better than placebo and on turmeric being or curcumin being better than placebo. And so, right, just like you said, that was the rationale.
In both
Yeah,
in functional dyspepsia,
in functional
which is cool.
dyspepsia.
Yeah,
Hmm.
not just like for reflux or something like that, but both for functional dyspepsia, which I thought was actually really interesting.
Yeah, there's a surprising amount of like research on curcumin, especially in GI conditions. I use it for a lot of different stuff. I did not use it for dyspepsia until now, but we'll talk about that in a little bit. One other thing I wanted to highlight on the first page, just like from the red flag approach to looking at papers, you glance through the affiliations with the authors. I didn't see anything suspicious. They all look like they work at hospitals or universities. I didn't see any conflict of interest statement. Do they have a conflict of interest statement on the
They
last
do.
page?
They have it all the way at the end.
Although at the end.
Yeah, basically it was partially funded by government. No one had
Right.
conflicts of interest. There was no public input into the study either. They were very transparent with everything.
Yeah, I thought that was good, and no red flags from like where
Hmm.
they're affiliated with. And then also the other thing that I do glance at for the abstract is the title registration. And so
Hmm.
they did register the trial, which is always important. One thing, just to nitpick, so I looked up the registration number. It's a Thai registry for clinical trials, and it was registered, which is great. Like that's awesome, but it wasn't prospectively registered. So you can kind of get a sense of that if you look at the number. It starts with 2022 12. So they registered it like a couple months before publication, which tells me, reading between the lines, that they submitted it to the journal, and the journal's like, we will not allow this to be published without a registration number. So they quickly post hoc registered it. That would be my suspicion. But even so, like it's better than nothing, but it doesn't help us in terms of, did they change their outcome measures? Did they change their analysis plan after they saw the data? We'll just have to kind of take their word for it. But that's kind of a little bit of a nitpicky thing. Awesome. Okay, yeah. What else you got?
Okay, so I mean that was mostly it from the introduction, and then from a design standpoint, they were very clear about it. It was a multi-center, and I thought it was kind of funny they said multi-center. It was really just two. Um, Double-blind, randomized, placebo-controlled trial conducted in Thailand between 2019 and 2021.
Nice. And I guess the only other thing to note, it was a equivalence trial. So the goal was not to see if curcumin was better than PPIs, but rather to see. So there was three arms, right? So there was curcumin, there was omeprazole, and then there was the combination of the two,
Hmm.
like sort of a
Hmm.
synergy theory. And the theory and the design was such that, can we show that they are at least similar-ish to each other, or not? And that's sort of the design. And that's a little. We've talked about non-inferiority trials before. This is a little stricter even than a non-inferiority trial, because you do need a larger number of people to say that it's not too different. You're not just saying it's not worse than. So no red flags for me there. There was good data to say that both interventions worked with Cochrane, and so they didn't feel the need to prove that one was better than the other, just to see if they were non-inferior, or not. Sorry, not inferior, but equivalent-ish. So yeah.
And I think this is the first equivalency trial that at least I'm aware of that I've read. I've actually never seen any authors directly state it was an equivalence trial. I've only seen non-inferiority or sort of like these superiority trials, if you will. So it was really interesting to see that this was a quote unquote equivalence trial.
Yeah, it's rare, and I don't see a lot of it too. And so that, of course, like, I sort of raised my eyebrows a little bit and did a little bit of digging, but I don't see any red flags from it. It makes sense. I think it's just not commonly used. And again, it's even stricter than what we would normally see, which is the non-inferiority. So I was okay with it, but I agree, it's super rare design. But this is important because of the way we interpret results. So normally in a regular trial, in a superiority trial, a null effect, meaning like there's no difference between treatment and placebo, is quote unquote a bad thing, means it doesn't work. Here, a null effect, meaning there's no difference between group A and group B, would be good. It would be that there's no difference between using omeprazole versus curcumin, and we know that they both work from previous trials.
Which I
Okay.
think is clinically
Mhm.
relevant too, because if you're having
Yes.
shared decision making with patients, you can say, "Hey, we've got two options. One's a medication, and one's not a medication. Both seem to be equivalent, at least based on this data that I have access to. Which route do you want to go?"
Yeah, and I thought throughout, actually, it was very clinically relevant. I'm
Oh yeah.
sure there were a lot of clinicians on this panel just because of the way the questions were asked, and like you said, the study was designed. So I love it so much that I feel like the results are immediately applicable to me in clinic. So yeah, awesome. See, what else did I like?
Do
Study
you think
population.
that
Yeah.
this would
Mhm.
be, and perhaps we can table this towards the end? Is this a trial that is immediately practice changing for you, and or something that should be implemented in guidelines?
The guidelines I'm not sure about. It is for me. I'm going to change the way I practice for this one. And we can talk about that maybe at the end. But yeah, it passed the sniff test for me, and I thought it was useful. But yeah, let's talk more about that at the end. So a little
Sure.
foreshadowing there. Um, so also the population was good. They made sure all the patients that were involved, and there were a lot of them. There was like 200 or something.
Yeah, so
Had yeah.
maybe we talk about the eligibility criteria, who was
Sure.
actually in the study.
hmm
And so basically, they had to satisfy the Rome 4 criteria for the diagnosis of functional dyspepsia. They were adults between the ages of 18 and 70 years of age,
hmm
willing to complete an EGD, basically an endoscopy.
Yep.
They were not using aspirin or NSAIDs, so things like ibuprofen, Aleve, diclofenac, those kind of things for the past 3 months. No use of a proton pump inhibitor for the past 4 months. So no omeprazole or Nexium, no other sort of variations of a PPI. No use of curcumin containing products or foods for the past month. I think that might be the more challenging of the eligibility criteria, given just sort of the location as to where the trial was conducted.
Mm.
No use of dietary herbal supplements that were in use for the promotion of GI health or anything that could affect the GI system. And then they didn't have a diagnosis of IBS, inflammatory bowel disease, H. pylori, any sort of esophageal disorders, reflux. They weren't pregnant or breastfeeding. Didn't have gallstones. And then importantly, they didn't have an allergy to curcumin.
Yeah, and I think that's a very clean inclusion criteria because it's very clear that this is the correct diagnosis. The EGD and the exclusion of IBS and other functional disorders means that, yeah, this is not explained by other conditions that can cause the same symptoms. This is functional dyspepsia, at least according to how Rome 4 diagnoses it. Yep, I liked it. What else you
Okay,
got?
excellent. And then basically, they randomized participants into one of three groups in blocks of six. So meaning, 6 people in one group, 6 people in another group, and then 6 people in the third group. And so they were randomized either to curcumin containing group, so curcumin only plus placebo.
Oh, yeah, what was the dose? I don't think we've mentioned the dose yet.
The dose was 250 milligrams, and they took 2 capsules 4 times a day. So that would be
A gram.
2,000 milligrams total, which is a pretty heavy dose.
I'm sorry, 2 grams. Yeah, sorry.
Yeah, 2 grams. When it comes to things like osteoarthritis, a lot of those trials are looking at like anywhere from 500 to about 1,600 milligrams is what I've most commonly seen. So 2,000 milligrams specifically for a GI condition, I thought was actually pretty interesting. So a pretty heavy dose of
Yeah,
curcumin.
hefty dose.
And what they did was they had a quote unquote curcumin only group, but really that was curcumin plus placebo. There was an omeprazole only group, which was really omeprazole plus placebo. And then they had a combination curcumin plus omeprazole group. Um, and then randomization was concealed using opaque concealed envelopes, and clinicians, participants, and data collectors were all blinded. So overall, from a method standpoint, this was a very, very um, well conducted study, low risk of bias, and they were very clear with how they were reporting this.
Agree. Yep. Randomization looked great and blinding looked great. Well, let's talk about blinding actually. Did blinding look great? So, um, you had mentioned earlier that curcumin is very tasteful and it has lots of taste and it has lots of color.
Mhm.
I always wonder with herbal products, they say it's double blind, but did that blind last or was it unmasked just from how obvious the taste and smell from burping and taste and things like that can be from different herbs. So I will talk more about that later, but it was set up properly. I'm not sure if we can fully trust the masking, but we could talk more about that in a little bit.
I think they did do a a masked placebo.
No, right. But the question is, was it unmasked? Right. So like,
Or
if
not masked. Sorry, identical is what I meant. Sorry.
yeah, so agree, right? But then you start taking it and you start burping up turmeric smelling, tasting stuff. And if you're in the placebo group, you don't. Or if you're in the
Hmm.
omeprazole group, you don't. So has that blind now been unmasked is the question. And I think that's a big issue that's under discussed in a lot of herbal medicine trials.
Yeah. Yeah, I think that's something that that you need to take into account. But yeah, do you think that would influence the results significantly?
Well, let's think this through. So you had one group with curcumin and placebo, so they would burp this up. You had another group with curcumin and omeprazole, they would burp that up, and another group with nothing. Um, and everyone was told they were on either active, no, not nothing, just omeprazole, right? So there was
Well,
no one on.
omeprazole plus placebo.
So right, omeprazole plus placebo, curcumin plus placebo, and curcumin plus omeprazole. So 2 out of the 3 would, in theory, be burping up these curcuminoid tastes or this turmeric taste. And so you could argue that if those groups were unmasked and there was an expectation of benefit for turmeric, that they might have overly rosy benefits when compared to the omeprazole group. One could argue. So that's one thing we should just kind of think about when we look at the results.
Yeah, exactly.
All right, cool. What else you got?
Yeah. And then when they looked at the primary outcomes of interest, it was what was called the SOTA score, which is Severity of Dyspepsia Assessment. And they looked at it at baseline. So they compared, just at the start of the trial across all 3 groups, at day 28, which was the conclusion of the trial, and then at 56 day follow-up. So one criticism of this trial is that it is short duration. It's only really 4 weeks of intervention with another 4 weeks of follow-up. So we don't have long-term data on this. We do seem to have some short-term data though. And then secondary outcomes were safety outcomes with an emphasis on looking at liver enzyme elevation. So comparing baseline to end of trial.
Nice. And a couple things to add about that. So one, just real quick, whenever we have an herbal product, we always worry about quality. So if you have like a null effect, which in this case is good, but in most cases it's not, you always want to make sure that the herbs were actually what they said they were. Maybe they weren't active or they weren't done well, etc. They do have a section here describing how they went through a quality assessment of their product to make sure that it was potent and what they said it was. So you always want to look for that with a herbal medicine trial. The other thing I want to say briefly, can we do a quick aside on the SOTA score? So I don't know SOTA. I don't know that particular score. And so I thought this was a good example for listeners. So it's very important when we're looking at outcomes to get a sense of what is a difference that matters, this minimal important difference issue that we've talked a lot about. And when you have when you have an outcome measure you're used to, like if you treat this all the time and you use this scale all the time, you might have an intuitive sense of how many points of improvement actually mean something to a patient. So I think for this, so I did just some quick Googling and found that it's a 0 to 40 point scale. Higher numbers are more severity. So we're looking for drops in those numbers. It's out of 40. So as a general, so that sort of gives us a sense. Now, how much of a difference matters? First thing I always do is try to Google around and PubMed around and try to find a published minimal important difference for that instrument. I could not find that. That is almost always the case. There is no good repository of this. There is one now, but they won't release their data as their paywall, and you have to be like a researcher paying them thousands of dollars to get access to it. So this is a big problem. So as a rule of thumb, though, there are 2 things you can look to for minimal important difference surrogates. So one is about a 10% change in the scale. So this is a 40-point scale. So first thing you might look for is, okay, do we see changes that are like around 4 points, right? So that would be one thing I would look for. The other is, and this is more established in the literature, is a half a standard deviation of the baseline level. So that sounds a little scary, But all that basically means is you're looking at how people, the range or the variability of how people present with this score at baseline. And half of that we consider a minimal important difference. It is highly debated. There is a lot of literature on this. I have a talk we're going to post on Dr. Journal Club on this in the near future. It's very cool information. Apparently, there's like some psychometric rationale for why that's a thing. It like plays into like human discriminatory ability. It's like really interesting science. But at the end of the day, like when you look across all these studies, a standard deviation is actually like pretty darn close to a minimal important difference. So what I did for this one was there's almost always a table 1, which is the baseline table. So if you go here, it's actually not table 1, that's the baseline table of the study participants, but table 2 has the SOTA scores, both baseline and baseline for the SOTA scores. And so what I just looked at real quick was, okay, here are the SOTA scores across the different groups. It would be great if they were pooled, but they're not. But they're all pretty close, so it's probably okay. And I see, okay, pain intensity SOTA score in the curcumin and omeprazole group is 25.8 plus or minus 3.22. I quickly look on the bottom, and it says that plus or minus is a standard deviation. Perfect. So I know for the pain intensity subscale, I'm looking for about half of that, like 1.6 or so, to be a minimal important difference if we do the half a standard deviation. And just to cut to the chase, the other ones are another 1.6 as well and 1. So when we're looking at the subscales of SOTA, at least according to this sort of rule of thumb, we're looking for a 1 to 2 point change being a minimal important difference. So when we get to the results, we can kind of eyeball that. Ideally, of course, they talk about all this, but no one ever does. And I think it's so important. So anyway, thanks for allowing me that tangent.
Yeah, and I mean they kind of said that, but they didn't mention the whole minimal clinical important difference. The way that they obtain their sample size, so how many people do we need basically to show any sort of effect? They assume the way that they calculate their sample size was on the assumption that there would be an improvement in the SOTA scores by at least 2 points, assuming a 10% dropout and a statistically significant p-value of 0.05. And what they found was that in order to find that, they would need a minimum of 63 people per group for a total of 189 needed for this study. And then if we assume a 10% dropout rate, that would actually really need to be about, I think 126, a total of around 200 people in order to sort of satisfy that 189 total. So basically, they would over recruit and have more people in the study than they actually needed, assuming that about 10% of people would drop out. And so they aimed at getting 70 people per group for a total of 210.
Perfect. Good. Yeah. So they were even powered for this level of change, which is fabulous. Look, the thing is, we don't do this for money. This is pro bono. And quite honestly, the mothership kind of ekes it out every month or so, right? So we do this because we care about this. We think it's important. We think that integrating evidence-based medicine and integrative medicine is essential. And there just aren't other resources out there. The moment we find something that does it better, we'll probably drop it. We're busy folks. But right now, this is what's out there. Unfortunately, that's it. And so we're going to keep on fighting that good fight. And if you believe in that, if you believe in intellectual honesty in the profession and integrative medicine and being an integrative provider and bringing that into the integrative space, please help us. And you can help us by becoming a member on Dr. Journal Club. If you're in need of continuing education credits, take our NANCIAC approved courses. We have ethics courses, pharmacy courses, general courses. Interact with us on social media, listen to the podcast, rate our podcast, tell your friends. These are all ways that you can sort of help support the cause. All right, should we jump into results?
Yeah. And then, so they just last thing, they also used an intention to treat analysis, which we always like to see, meaning that they analyzed based on which group they were randomized in. So it was not a per protocol.
But also along that line, the other thing to look for, because intention to treat, you're right, better than per protocol, but also not always clear, is how they dealt with missing outcome data. and at least they report it, which is great. Like to your point, that it's a well-reported study. And let's talk more about this when we get to the flow chart. But the way they dealt with missing data was to use last observation carried forward, which we'll kind of talk about.
Yeah, let's talk about that now. I'm actually glad you brought that up. Yeah.
So essentially, like when you do a study in real life, people disappear. Like they die, or their parents die, or they have to leave town, or something like that, or they just get sick of the study. And if you drop out of the study for reasons that have nothing to do with the intervention, that's no problem. That's random. As long as that happens pretty equally across groups, not a big deal. If you drop out for something that has to do with the intervention, whether it's because it causes more side effects or you're not responding, and so you drop out, you censor your data in a way that has a particular direction of bias as opposed to random. And that's a big issue. And so the question is, well, what do we do with these missing data points? Like they came in at the beginning, they came in for the second study and the third study, but then they just disappeared. Do we just not count any of their information? Like we need that information. We've got some of it. What do we do with those missing trial visits? So there's all sorts of debates, and we've got stuff on the website about how to do this properly. I disagree with the way they did it. But it's very common to do this last observation carried forward. Basically, it says, okay, if your SOTA score was a 30 and then a 20 and then a 20 and then, or let's say it started at a 40, then it went to a 30, then it went to a 20, and then they dropped out. You would just assume that the other visits they missed were 20, 20, 20, right? The problem with that is if the reason they dropped out had to do with it not working, right? So let's say their levels were 40 and then 40 again, and then 40 again, and they dropped out. What would happen? You would carry 40 across. So that would be more conservative. What if it was 20 and then they drop out and you keep it at 20? And really what happened was it stopped working for them. They bounced back up to 40. Now you've basically been too rosy in your estimation. And as long as it balances out, like maybe that's okay. But the fear, of course, is that people are leaving because it's not working for them. And you're leaving everyone in the trial where it is working for them. And so you're basically censoring the data as it would have gotten worse. Like let's say it started at 20 and it was worsening, but then you censor it at 30 and you never caught the fact that they went up to 40 at the end. So that's just sort of an issue there. As a quick aside, the way I like to do it is to do it as a sensitivity analysis, and basically to say, assuming the worst plausible assumption about this missing data, do the results still stand? But that's a little bit of a aside. Okay, go ahead. Sorry.
Yeah. No, great. Thanks for that and clarifying that. And then, okay, let's look at our results. So 241 people were assessed for eligibility, and 206 individuals were enrolled and randomized. And remember, they wanted a total of 210. So they were just under with regards to that. And then that 206 was split up as 69 individuals in the curcumin group, 69 in the curcumin plus omeprazole group, and 68 in the omeprazole only. Unfortunately, there was overall a pretty large dropout rate. In total, 55 people dropped out, which makes up 27% of the study population. And then when you actually look at the dropout rates across all three groups, they're pretty even. You had 23% in the curcumin and omeprazole group, 29% in the curcumin only, and 28% in the omeprazole only. So nothing there that really stood out where one group led the other. But still a pretty high dropout rate that wasn't explained. And I thought from the get-go, their assumption of a 10% dropout rate was pretty bold. So I don't know if you want to speak onto that, Josh.
Yeah, I mean, I agree. I think just based on the percentage of people that dropped out, this would be high risk of bias. Like if we were to do a proper Cochrane risk of bias assessment, the thing that has me scratching my head, and I think a month of herbs or omeprazole, like I wouldn't have thought that many people would drop out, but you've got more experience running clinical trials than I do, and maybe it was overly rosy. But the thing that gets me confused is, yeah, overall, the percentage of dropouts are the same across group, but the reasons are very different. And you want to look at the reasons to see if, again, the dropout is associated with side effects or maybe unmasking. So that's why I was looking at it. And you see, it's very weird. So for the curcumin and omeprazole and the curcumin group, so these are the groups that actually got the curcumin product, 14 out of 16 and then 17 out of 18, out of 20 were lost to follow-up with no rationale as to loss to follow-up as why. But then the omeprazole group, there was just one loss to follow-up and 18 consent withdrawn, whereas the other two groups, only 2 people had consent withdrawn. So, I mean, it could be randomness, but the difference there is like dramatic. And I'm very unclear as to why that would be. Like, why would you withdraw consent, and why was everyone in the omeprazole withdrawing consent? And one story you might tell is, maybe they felt like they were getting the quote unquote placebo because they didn't taste or feel anything when they took it, and so they just said peace out. Whereas in the groups that got curcumin, they were less likely to do that because they burped up and tasted it. It was unmasked, and they felt like they were getting the active intervention, which of course would lead to blinding issues. So I don't know. I've just made that up. But when you have some worries about unmasking and you have uneven either percentages or reasons for missing outcome data, it's just confusing. But I think regardless, because the percentage is so high, I'd rank it as a high risk of bias for that anyway, and maybe trying to tease out what direction would be is kind of moot.
Yeah. Good point. But yes, okay. Moving forward, at baseline, the SOTA scores are basically equal across all 3 groups. And then there was also at day 28, when we looked at our primary outcomes, the SOTA scores basically improved equally across all 3 groups. In the curcumin only, there was a reduction in pain scores by about 5.5. In the omeprazole only group, there was a reduction in pain by about 6, and then combined a reduction in pain scores by about 5. For non-pain symptoms, basically all 3 groups had a reduction in scores of 2. And then overall satisfaction was a little bit higher in the curcumin group, with just under 1 point improvement in satisfaction scores. So basically what we're seeing is that the curcumin is, per this study, equally efficacious in symptoms of functional dyspepsia when compared to omeprazole.
Yeah, pretty cool. And all those changes are above those guesstimates of the minimal important difference, like multiples of it in many cases. So these look like real meaningful changes. There's no difference between groups. And then also that's interesting because in the synergy group, we don't see evidence of synergy because
Right.
the benefit is about the same as taking curcumin alone or omeprazole alone. So that's curious too, that adding, this works, that works, but adding them together doesn't work twice as much type of thing.
Yeah. And then also from a safety standpoint, there really wasn't much of a difference. However, there was a trend that was occurring where individuals who used curcumin tended to have elevations in their liver function tests, and that difference was about 8% when comparing curcumin groups versus omeprazole groups. Now, just because you're having liver elevations doesn't necessarily mean it's something to freak out about. It depends on what the magnitude of those liver elevations are. Are you just a couple points above the reference range, or are you 3 times the upper limit of normal, where, hey, this is actually something that we should really pay attention to? So there is some clinical insight there that needs to be taken into account. But something to definitely at least monitor is, hey, if you're going to be using this as a therapy, at least one safety thing that you should be doing is monitoring liver function before starting and at some point during treatment with someone. And if you are treating them, perhaps consider doing it at the 4-week mark, because you have the data from this trial to suggest it. And if the liver enzymes are going up, maybe consider stopping the intervention, or depending on how high those elevations are, continuing therapy.
Yeah, absolutely. Yeah, perfect. Very cool. Very cool results. What do you think? Do you think you change your practice at all based on reading this paper?
I think if someone came in with the diagnosis and, like, for sure we were working with functional dyspepsia, I would offer them both. because curcumin's not covered by insurance, and the majority of my patients are rely heavily on insurance to get access to care. And so if it's cost prohibitive, well, then I'll go with the omeprazole. If they have personal feelings as to wanting to use a supplement over a medication, I personally don't really care. But if they prefer using some sort of a quote unquote natural intervention over omeprazole, and that's what they want, great.
Yeah. Yeah. I think that's fair. And you could very clearly say, again, based on the design being so clinically relevant, that as far as we can tell, both work well in a way that would matter to you, and they work about the same. And that's
Yeah,
literally
at least in
what
the
this is
short
designed
term.
for,
We
at
don't have
least in the short
long-term
term.
data.
That's
So
true.
yeah.
That's true. Yeah, I agree. I mean, I'd be a little bit more bullish. I think curcumin is very cheap relatively as far as supplements are concerned, probably equivalent to over-the-counter cost of omeprazole, I would guess. So I don't know that cost would be a huge thing. And again, I have a biased population, selection bias. So the people that come to see me are more likely to be weary of or wary of PPIs, and also more likely to prefer natural supplements. Yeah, I didn't normally use turmeric or curcumin for functional dyspepsia before, and I see a lot of functional dyspepsia. So I'm actually going to start recommending it more. I did until now I'll usually recommend the PPIs based on the guidelines and the studies, but it's kind of nice to be able to say, at least according to this study, they seem equivalent. um, and also, and you and I have differed on this, I have a little bit more concern from a precautionary principle with PPIs than you do, although we
Mhm.
both agree the evidence level is low. It's just a matter of what you do with that and what the trade-offs are. But here's a good case where you could say, well, heck, as far as efficacy, it looks pretty equivalent, at least according to this one study, which we think is probably a high risk of bias. And then the other thing I would probably do based on those LFTs is I will probably recommend. So there's some herbs that I recommend for patients, and I say, you know what, we just need to keep an eye on your liver. So
Yeah.
usually every 3 months or so, I'll just have them get a CMP or something like that, or an LFT. So I'll probably do that for this one as well, based on that trend that they saw, just to make sure we don't see anything there.
And I think something else to take into consideration is you can probably get a twofer with a curcumin. Like if someone is coming in with like osteoarthritis too,
Mm,
there's a lot of pretty good evidence supporting the use of curcumin for that. And this is not medical advice, but just something to consider is if you have someone who is on polypharmacy and you want to try to reduce that, and they have sort of preference for non-medication use, or you don't want them on like long-term ibuprofen use because of the known side effects associated with that. Here's an option of something that we can consider where in a lot of randomized controlled trials, we do have comparison of curcumin to typical NSAID, so ibuprofen,
hmm
and some good quality trials of that. And now we have something for omeprazole, so sort of get 2-for-1 with the use of curcumin at a relatively high dose. And this dose would be acceptable for both
Yeah, good hefty dose.
osteoarthritis and functional dyspepsia. So I think that that's something that's really interesting.
hmm
And I think we also have to be cautious. This is curcumin, not turmeric.
Yes,
How much turmeric you would have to use to get an equivalent dose, I don't know, but my assumption is that it would be
much
very,
more.
very high. And something that I see a lot is, you have to supplement with curcumin with, a fatty meal and black pepper to increase the absorption.
Yes,
They
good.
didn't have to
Yeah,
do that for this trial.
yeah, very good
So
point. Yeah.
if someone is buying a supplement or recommending a supplement that is 10x the cost because it has magical properties to it
hmm
and magic jelly beans inside of it, perhaps you don't need to do that.
Yeah, that's such a good point. So for the cost thing, like curcumin is cheap, but the fancy curcumin that's like quote unquote bio, well, it is bioavailable, like 95% bioavailable, stuff like that. Because like the issue with curcumin is it's just hard to absorb.
Hmm.
And so these companies have come out with these products, and I normally recommend that for the same rationale that we better absorption. But this is such a good point, is that here we have really strong, well, not strong, but we have good clinical data suggesting that just straight old curcumin is working just fine. Thank you very much. And that's the cheap stuff. So I think that's an excellent point and something to underline here as well. I love turmeric. I love curcumin. I use it a lot for IBD stuff. Um, but I have not used it for dyspepsia. So I'm very excited about that. So we'll see. And again,
And
this
it also feeds my bias of not caring about mechanism of action. Right? If you don't have to care about the
skipped that
reason.
whole section. I feel kind of guilty.
Even from like a clinical standpoint of like not needing the black pepper and taking it with a fatty meal and stuff like that, it's like, hey, based on this really well done trial that doesn't actually matter. So cool.
That's the armchair physiology thing. It gets you every time. It like people sound so smart and go through all these graphs on PowerPoint showing that why you need to buy their fancy product, and then you run the darn trial and the cheap stuff's absolutely just fine. So I really talk to patients a lot about this. Is like, beware of the armchair physiology arguments. Sometimes it's reasonable to make them, but it's no substitute for real hard clinical data like we have here. So cool, man. I thought this was a very useful paper. Thank you, Dr. Winship, for recommending it, friend of the pod. And any last thoughts?
No, that was a fun paper to read, and now I've got a little feather cap in my hat that I can use, and I hope people find this podcast and paper helpful.
Yeah, awesome, everybody. And of course, this podcast is mostly for clinicians. If you're a patient listening, talk to your doctor first. This is just clinicians talking amongst clinicians about research. Alrighty, see you all later. Bye-bye. If you enjoy this podcast, chances are that one of your colleagues and friends probably would as well. Please do us a favor and let them know about the podcast. And if you have a little bit of extra time, even just a few seconds, if you could rate us and review us on Apple Podcast or any other distributor, it would be greatly appreciated. It would mean a lot to us and help get the word out to other people that would really enjoy our content. Thank you. Hey, y'all, this is Josh. We talked about some really interesting stuff today. I think one of the things we're going to do that's relevant, there is a course we have on Dr. Journal Club called the EBM Boot Camp that's really meant for clinicians to sort of help them understand how to critically evaluate the literature, et cetera, et cetera. Some of the things that we've been talking about today. Go ahead and check out the show notes link. We're going to link to it directly. I think it might be of interest. Don't forget to follow us on social and interact with us on social media. At Dr. Journal Club, Dr. Journal Club on Twitter. We're on Facebook, we're on LinkedIn, et cetera, et cetera. So please reach out to us. We always love to talk to our fans and our listeners. If you have any specific questions you'd like to ask us about research, evidence, being a clinician, et cetera, don't hesitate to ask. And then, of course, if you have any topics that you'd like us to cover on the pod, please let us know as well.
Thank you for listening to the Dr. Journal Club podcast, the show that goes under the hood of evidence-based integrative medicine. We review recent research articles, interview evidence-based medicine thought leaders, and discuss the challenges and opportunities of integrating evidence-based and integrative medicine. Be sure to visit www.drjournalclub.com to learn more.